Good morning and welcome to today's Infectious Disease Echo. Today is February 9th, and today we are talking about meningitis. And we're going to start with the epi overview, which is going to go through respiratory illnesses. And I will display a link in the chat. I'll go ahead and display it for you to fill out for evaluation purposes. And we do have a couple announcements. Next month's Echo is going to be on Wednesday, March 13th. And from there on, it's going to be on Wednesdays, the second Wednesday of every month. So with no further ado, I guess, Anna, you can take it away.
Perfect. Thank you. All right. All right. I'm hoping you can all see my screen. Yes. Okay, perfect.
Yes.
All right. So we'll just start by going over our seasonal respiratory illnesses report. So this is a report that we put out weekly. It gets sent via alert on Thursdays, and Greer works with me to do this. So Greer has been a major help in doing this. All right. So this is the same thing that we have presented at all the previous echoes. So it is just metrics on COVID-19, influenza, RSV, and influenza-like illness. This is data based on the USET aggregate, so it is not tribal nation specific. It is an aggregate of the USET area. All right. So this data is based off the morbidity and mortality weekly report, so the MMWR week number. That is just the week of the epidemiological year assigned by the National Notifiable Diseases Surveillance Disease Report for the purposes of disease incidence reporting and publishing. Basically, it's just the week number that we're in of the year. So the first week of the year was week 1, just for consistency. So first, starting out with influenza-like illnesses, you can see right here, we are on week number 4. This report was sent this past week. For our national IHS percentage of IAHS ILI visits, we are down just a little bit from the previous week. We are at 4.5%. The Nashville area is just slightly above that at 4.6% this week, with a decrease from the week before. So for the percentage of ILI visits by age, we see the highest age group here is 0 to 4 years at 10.2%. And then this is following that similar trend that we've seen all season, kind of decreasing percentages as the age increases there. Our influenza-like illness activity level by state, we see here we are decreasing from the previous kind of weeks and months. We are seeing more of this green color indicating the lower levels of ILI activity. We are still seeing relatively high levels in some of our USET states down here in the south, but these kind of northeastern states are more of this green color. So we are kind of trending downwards for this ILI activity. For the percentage of outpatient visits for respiratory illnesses, the current year is this green color. So you can see week 4 right here. We had this higher peak, near the end of the year, December, early January, and now we are coming down from that. And this is following the similar patterns that we've seen over the past few years. So that is good news. All right. So COVID-19, influenza, and RSV. So this chart here is comparing those different illnesses. So we have the combined metric here in red. So that's the combination of all 3 of those. We can see here we did have a little bit of a peak and we are dropping off. All of the other metrics are following that similar trend. So we have influenza here in the black line. That is the highest of the COVID, RSV, and influenza. Next, we have the COVID metric, that's at about 2% of visits, and then we have influenza, which is 0.3. So those are all kind of steadily decreasing as we go on here in the year. The percentage of respiratory visits by USET states, we have the whole United States as the comparison in this yellow color here on the right. That is at 5.5%. We have all of the USET states listed out here. We have Texas at 9.1% is the highest of all USET states. And then we have Maine at 3.8% is the lowest of all USET states. So you can see here, if your tribal nation is in one of these states, kind of where you're falling in comparison, to the entire United States. For influenza specific, and this is confirmed by test, we have our seasonal influenza vaccination percentage by IHS region over here on the left. We have the national in this first red bar here at 29.1%. These are the patients who have received one dose of their seasonal influenza vaccine. The next red bar here is the Nashville area. That's a little bit higher actually than the national at 29.7%. So we are doing a good job here. Over here on the right, we have our IHS seasonal vaccination percentage by age group. We have the total of all age groups 6 months and up at 29.1%. We start with 6 months and up just because that is the first kind of recommended age group to get that vaccine. So we see the majority here of 65 years and older at 53.6%. So that's the highest kind of age group getting those vaccinations, followed by 50 to 64 years, and then those infants at 6 to 23 months. So over here on the top left, we have a pie chart of the percentage of positive influenza specimens by type for clinical laboratories. We are seeing a majority here in this red color of influenza A, and then 26.9% as influenza B. That's been a similar trend throughout the season. Over here on this top right-hand side, we have the IHS Nashville area seasonal influenza vaccination percentage by age group. This is specific to the Nashville area for these age groups. So children 6 months to 17 years is at 24.4%. And then seniors 65 years and older is at 56.8%. These two bottom metrics kind of go hand in hand here. So this is the number of new hospital admissions with influenza by HHS region. So depending which tribal nation you are in, you fall into one of these regions, 1, 2, 3, 4, or 6. So week 3, we have the numbers listed out here as well as the total. And then for week 4, which is our current week here, we do have those specific number of hospital admissions listed out as well as the total in the United States. Over here on the right, we have the comparison of the percentage of new influenza hospitalizations by week, again by HHS region. We have year 3, which is the previous week in black, and then year 4, which is our current week we're reporting on in yellow. And you can see these are, pretty similar week to week. Here we do have a slight increase in region 6, but all the other regions are staying relatively similar or decreasing just a bit. For COVID-19 specifically, our variant of concern is this Omicron JN.1. That's been holding consistent as well. Our weekly COVID-19 case positivity rate. So this is comparison between the whole United States and then those specific USET states. We have the USET states here in this red color and then the United States in yellow. We're seeing they are following a pretty consistent trend of dropping off here. So that is, again, good news. The United States percentage for this past week was 7.8, whereas the USET states was 6.3. Or I'm sorry, I said that in the reverse order. So the United States was 7.8, whereas the USET was 6.3. So our weekly COVID-19 hospitalization rate per 10,000 people, we have our United States in this yellow color here, and then the USET states in this red color. We see USET states is just a little bit higher, but pretty similar here. Finally, our weekly number of COVID-19 hospitalizations. We have the United States hospitalizations at 22,636, and then those specific in the USET region at 9,406. Again, we do offer a tribal nation specific report. This would be sent directly to your health director and would not be, publicly shared. It would be fully customized for your tribal nation, and it could include state-specific data, but you must opt in to receive these reports. So if you are interested, you can contact either Greer or I, or you can email the general USET EPI email address. We do have our webpage here, QR code if you would like to view that or see anything else that we have been up to. That is the end of the EPI update.
Great, great presentation. Do we have any questions for Anna or the EPI team at this time?
Yes, I have a question, and that was a really wonderful presentation, by the way. Is that offer at the end, your last slide, for tribal nations within USET or any tribal nation?
Yes, so that is specific to USET member tribal nations. So any one of the 33, that's just a service we offer to those, USET member tribal nations. And we would just need, the health director to kind of give us that consent to go forward.
Thank you.
Hearing no further questions, Dr. Murray, you want to pull up your presentation and go ahead and get started?
Sure. Give me 1 second. Try to. Okay, can you see them correctly?
Yes.
All right. Okay, thank you. And thank you for the invitation to talk today. So I'm going to be discussing community-acquired bacterial meningitis. The acronym is CABM or CABM, just to make it short on the next slides. And I'm going to focus on adults, not on pediatrics. So when you go to the, there's many definitions for this, but I think this is the most important one, and that's the first thing. This is a medical emergency. So every hour that goes by from diagnosis to treatment, or from, let me put it this way, from admission to the hospital to treatment, the mortality increases, and I'll show you some more specific data on this later. So it requires an immediate diagnosis. You have to have a very low threshold of suspicion, and to start effective treatment immediately. And I underline effective because it's not just giving the patient antibiotics, because if they are not going to work for the etiology that the patient has, the mortality still will increase. And when you do not, in the pre-antibiotic era, bacterial meningitis had 100% mortality. So in adults, the most common etiologies are strep pneumo or pneumococcal meningitis, meningococcal meningitis, or caused by Neisseria meningitidis, and Listeria monocytogenes, which that occurs mainly in the individuals who are older than 50 years old, or regardless of age, anybody with cell-mediated immune deficiencies. Now, there are other causes. These are not the only bacterial causes, but if you encompass these three, it'll probably cover 95% of the causes of bacterial meningitis in adults. Haemophilus influenza, which is a cause in infants, not very frequent anymore due to vaccination, may be a cause here, but it's very less than 1%. That's why I did not include it. So the clinical presentation, first, patients with bacterial meningitis are extremely ill. So this is not a patient that's just complaining of a headache. Headache is present and it's usually severe in 84% of the patients when they show up. Fever is present in 75% of the patients, 74%. Nuchal rigidity in 74%, and change in mental status in 71%. So the importance of knowing these four signs and symptoms is that if they're absent, that excludes bacterial meningitis. If a patient doesn't have any of these four, they don't have bacterial meningitis. But if a patient has two out of these four, they can come in with a severe headache and a fever, 98% of the patients will have at least 2 out of those 4 symptoms. So that is important to know. The classic triad is fever, knuckle rigidity, or stiff neck, and change in mental status. That's the classic triad that we teach our medical students, but not all patients will have all these 3 manifestations. But the majority, if not all of the patients, will have at least 2 out of 4 of these 4 manifestations that you see there. So that's why it's important to know them. So there may be some clinical clues of what agent is causing the meningitis. I think this is more for teaching purposes, because you're not really going to use this to decide treatment. You are going to treat empirically for all of them until you find the pathogen, and then you may titrate the treatment to the specific pathogen. But patients with pneumococcal meningitis have a higher incidence of strokes, and also they have a higher incidence of recent sinusitis or otitis media. So if you see a patient who was improperly treated for bacterial sinusitis and comes up now with meningeal symptoms, then you can say probably this is going to be pneumococcus. Also, patients who've been recently prescribed antibiotics tend to have more pneumococcal meningitis and a history of head trauma. And that's some patients with head trauma have a cerebral spinal fluid leak, and that predisposes them to pneumococcal meningitis. Patients with listeria, first they usually have some immune compromise. But the other thing is that they tend to have seizures and focal neurologic deficits early in the course of the disease. So if someone presents with meningitis and a seizure, you would tend to think it may be listeria. But like I said, you're going to be covering empirically all these 3 pathogens in your treatment when you suspect that the patient has bacterial meningitis. And meningococcal meningitis, what is very typical is a rash, especially a rash that has petechiae or palpable purpura. Arthritis is more common in meningococcal meningitis. It is important to detect it because the treatment duration is going to be longer if they don't have arthritis due to the meningococci. If a patient has been recently exposed with someone with meningitis, you think about meningococcal because that's the only one that's transmitted human to human. And if the patient's been in certain parts of Africa and the Middle East where meningococcal disease is endemic, then so a travel history will also kind of guide you to that diagnosis. So how do you evaluate a patient that comes in with, let's say, a fever and a stiff neck? So first, remember, this is a medical emergency. So you need to evaluate this patient immediately. Don't have them sitting in the waiting area of the ER for 8 hours, or you will find a body, not a living patient when you go out and call him. Blood test, blood work should be drawn immediately, and we'll go over what blood tests are needed. And also a lumbar puncture is important to make the diagnosis. So every patient with suspected meningitis should have cerebral spinal fluid obtained, unless the lumbar puncture is contraindicated, and I'll show you which ones are the contraindications. In a brain scan, although it's done routinely, it really is not needed in the majority of patients, but there are some unique indications in that you need to get a CT scan of the brain. So what lab work do you need? You need a complete blood cell count, so with differential and platelet count. White blood cells, red blood cells, and platelets. You need to know the creatinine. The glucose is very important because you're going to use the difference in concentrations of blood glucose with CSF glucose to drive you towards a diagnosis of bacterial meningitis, and also the electrolytes. Many patients come in with severe electrolyte deficiencies, especially sodium. Then you need to get blood cultures ×2. Why is this important? Because 50 to 90% of patients with bacterial meningitis will have positive blood cultures. And let's say you cannot do DLP right away for whatever reason. You may start the patient on antibiotic treatment, and maybe you'll get lucky and you pick up the bugs in the blood cultures. Now, if it's pneumococcal, or especially pneumococcal, the blood cultures tend to be positive, almost 90%. But when you're having meningitis caused by meningococci, then that yield decreases, as well if the patient has been on antibiotics, that yield decreases. You'll need coagulation studies, especially if the patient has petechiae or purpuric lesions on the skin. So lumbar puncture is, or an LP, is critical for evaluation. And when you do that, it's very important to include the cell count, the bacterial culture, the glucose, the cryptoantigen. We still have a lot of undiagnosed HIV, and many patients that present with those symptoms of altered mental status and fever could have a cryptococcal meningitis, which is not bacterial. And then if you have availability of a multiplex PCR to do in the CSF, I would encourage you to do that. That basically tests for all the pathogens we mentioned and about 10 or 15 more. And it can be very helpful in guiding the diagnosis, especially if it's a viral meningitis. Also, it's very important to tell the lab, do not save some CSF fluid in case after the first evaluation, we decide that we need to order other type of tests like mycobacterial or fungal cultures, or other specific tests for other rare pathogens. For example, you admit someone with high fever and a headache, and you start them on antibiotics to cover those three major pathogens that I mentioned, pneumococci, meningococci, and listeria. But the next day, the cultures are negative, and then you get a history that the patient had a tick-borne tick exposure. So now the differential could be broadened to, could this be Ehrlichia meningoencephalitis? And then you'll need to order specific PCRs and serologies for that. That's why it's important to have CSF saved. Other examples that I can give you is if you live in the Southwest, like I do, coccidioidomycosis can cause meningitis. It's usually subacute, not acute, but sometimes, the bugs haven't read the textbooks. They can present in different ways. And then if you don't have that CSF, you're gonna have to do an LP again, because now you want to order specific tests to rule out coccidioides. Okay, so as I mentioned, the LP is critical, but there are some situations in which you cannot do the LP right away, and you'll need a CT scan before you do that. If there's any suspicion that the patient could have hydrocephalus or cerebral edema or a mass, and that happens, for example, if the patient's immune compromised, there could be many causes of meningoencephalitis, and so you need to make sure they don't have a mass. And if they have a mass, they're at risk of brain herniation, and that could be lethal. So in those situations, you would want to get a CT scan before you get the LP, but you do not want to delay treatment. So you'll start treatment, and after the CT, if it allows you to do the LP, you'll do the LP. If the patient has any bleeding disorders, like severe thrombocytopenia, and it's got to be really low count, usually less than 50,000, but actually between 10 and 50,000, you can still do an LP. Or the patient's on anticoagulation. Let's say they're on Coumadin, or they're on one of the other anticoagulation agents for any other disease, then you won't be able to do that LP immediately. You're going to have to defer it. And if you suspect that the patient may have an epidural abscess because they're having back pain, then you don't want to put a needle through an abscess and inoculate that into the CSF. So those are all the situations in which you would have to delay the LP pending other studies, imaging studies, but you still want to treat the patient immediately. So what are the indications for a CT scan? Anybody who's immune compromised, and examples are a patient who's HIV and has HIV positive, a patient who's on chronic immune suppressive therapy, any transplant, solid organ or bone marrow transplant patient should get an imaging of the brain done first. Why? Because there could be a mass. It could be an infection that causes nodules in the brain, and you don't want to do an LP and have that person herniate. A seizure, the patient has had a seizure within the last week, you need to get imaging just to make sure they don't have a mass. If they have a history of a mass or of a recent stroke or any focal infections, you would want to do imaging. If they come in with altered mental status, you will want to do that. And that it's a large group of patients. So this is why most of the treatment is going to be empirical and without an LP in the first hour. Now, CT scan can get done fast. They can get done in 20 minutes if you want to. Still, I recommend that you do not delay antibacterial treatment. Anybody who has a focal neurologic deficit, like they can't move a hand, an arm, a leg, or any cranial nerve deficits, you would have to do a CT of the brain. And papilledema, that requires fundoscopic examination, a rare thing that happens nowadays. I remember when I was a resident 200 years ago, we were obliged to do a fundoscopic exam on every patient. But now I think that's gone out of favor and people are just not trained to do it, but it's a pity. Okay, so what to do if the patient needs imaging or for whatever reason the LP is delayed. When I mean delayed is that it's gonna be more than 30 minutes or 20 minutes since you can get that LP done. Obtain blood cultures, as I mentioned, start empirical antimicrobial therapy as soon as possible. Then you obtain the LP as soon as you can, still will help you in the differential diagnosis. And if the suspicion for bacterial meningitis is high, and remember, anybody with 2 out of those 4 symptoms, my suspicion is high, you should give them dexamethasone before you start them on antibiotics. And a common mistake is that patients are giving antibiotics and then the dexamethasone. It doesn't work that way. If the patient got IV antibiotics in the ER, then you lost your train there and you should not give the dexamethasone. Why is the dexamethasone important? Because in pneumococcal meningitis, it decreases the brain inflammation and it decreases the adverse outcomes, like deficits after the patient has cured from the disease. So what do you expect to find in the cerebral spinal fluid? In bacterial meningitis, usually the white blood cell count is between 1,000 and 5,000, but the range is pretty broad. I mean, even people with less than 1,000 could have bacterial meningitis. Usually they have 80% neutrophils. The protein's pretty high, 100 to 500 milligrams, and the glucose is low. That's why it's important to get a blood glucose at the same time, because the most important thing is the CSF serum glucose ratio, which should be less than 0.4. Now, if you had a patient, and I should have put this on the slide, I forgot, but if you had a patient with viral meningitis, usually the white WBC count is much lower. It's around in the 100s range. The patients usually have lymphocytes instead of neutrophils, although they can have neutrophilia at the beginning. The proteins are elevated, but there are usually not above 100, and the glucose is usually normal for the majority of them. The other thing that you want to do is culture and make sure that lab does a bacterial culture of that CSF. But there are other techniques that use PCR or antigen testing or even sequencing, genomic sequencing in the CSF that are helpful for finding a diagnosis. There are several multiplex PCRs you can apply to the CSF. And this is basically, these PCRs detect like 15 different pathogens, including pneumococcal, listeria, meningococcal, but they also will detect enteroviruses, it will detect varicella zoster, a bunch of other viruses that can help you with the diagnosis. If a patient has increased WBCs in the CSF, even if the CSF is negative, sometimes you can pick that up on the blood cultures that are positive. And if the blood cultures are positive and there's leukocytosis in the CSF, you can confirm that that's a bacterial meningitis caused by that organism you isolated in the blood. But the absence of one or more of these typical CSF findings does not rule out the diagnosis. For example, you can have a patient that comes in with a white blood cell count of 200, that the neutrophils are 50%, that the protein is 80, and that the glucose is 60, and that patient could still have bacterial meningitis. So this is just a guidance. It's not an absolute diagnostic confirmation or exclusion. So the differential diagnosis is with a bunch of other pathogens like viruses, mycobacteria, fungi, or even parasites. And the CSF findings may overlap with these organisms. But you really need to treat the ones that I mentioned first, empirically. And then if anything in the clinical history or physical exam or in the CSF results are a little bit off for bacterial meningitis, then you may want to think of these other causes and consider the diagnosis and maybe empirical treatment if it's warranted. So how do you differentiate acute bacterial meningitis from all these? Well, the imaging may help. If you see our radiologists today are pretty savvy. They can see a lesion in the brain and say, this looks like a fungal infection. It doesn't look like a bacterial because it has these nodules with X, Y, or Z. Also, pay attention, detailed attention to the CSF findings. If you find lymphocytosis, or even if you find eosinophilia, that could guide you to, this could be cocci-meningitis, for example. And then the epidemiologic factors. Depends where you live, depends what you're exposed to, is the probability of having other types of infections. And the patient's medical history. If they're immune compromised, then it's Pandora's box. It could be anything. But if they're a young, non-immune compromised person, that pretty much narrows it down. So, excuse me. So what is the impact of not starting treatment rapidly? So this was a study. There's many studies that have been done. I just brought you one. This was a cohort study of 173 patients with acute community-acquired bacterial meningitis. And what they found that is a delay in antimicrobial therapy for more than 6 hours compared to 2 hours after admission increased mortality by 60% and bad outcomes by 50%. And here you can see the same study, eliminate this pre-hospital, because these were patients who received antibiotics before in the community, so they excluded these pre-hospital. The bottom graph is unfavorable outcomes after discharge, meaning the patients had neurological deficits. And the top graph is in-hospital mortality. So here you can see that if the delay in antibiotic treatment was less than 2 hours, mortality was 14%. It was 2 to 4 hours, 16%, 4 to 6, 20%, and more than 6, 30% mortality. So that's why it's so important to treat as early as you can. And again, the outcomes after discharge, if the patient could receive treatment after 6 hours, 60% had neurological deficits that were severe. So treatment, as I mentioned, treatment must be empiric, meaning you're not waiting for results to treat the patient. And it will depend on the patient's age, the drugs, the antimicrobials that you use, the presence or absence of immunosuppression on that patient, and the local antimicrobial sensitivity patterns of where you live. I'm sorry, there was a typo in patterns. Treatment may be tailored when you have your CSF gram stain results. For example, you treat the patient, and I'll show you with what antibiotics to cover all 3 bugs, but then the gram stain comes back and says you have gram-positive diplococci. That's very typical of pneumococcus. Or it says you have gram-negative diplococci. That's very typical of meningococcal disease. Or you have rods, and that's very typical of listeria. So you can change your treatment after you get that, but usually we wait until we get the culture or the PCR or antigen test to make sure we're not making a mistake. So the empiric treatment, the mainstay is 3rd-generation cephalosporins, specifically these 2, ceftriaxone or cefotaxime, and we use ceftriaxone because it's you can give it every 12 hours instead of cefotaxime that you need to give it every 6 hours. Both of them have really good CSF penetration, and they have bactericidal activity, but they are not active against Listeria, and they're not active against penicillin-resistant pneumococci. So you're going to have to add something to this ceftriaxone. So if the prevalence of penicillin-resistant pneumococci is more than 1%, you need to add vancomycin. And in the United States, it is more than 1%. So in the US, patient that comes in and you suspect they have bacterial meningitis, you need to give them ceftriaxone plus vancomycin for sure. Always give the dexamethasone before you start the antimicrobial treatment. Later, if it is confirmed that it's pneumococci, you'll keep the dexamethasone. If it's not, you'll stop it. Okay, so ceftriaxone and vanc, everybody gets. Now, patients with no known immune deficiency, it's what I just mentioned, ceftriaxone plus vancomycin. If the patient is older than 50 years old, you have to add ampicillin because that covers Listeria. And if the patient's immune compromised, regardless of the age, the treatment will be vancomycin plus ampicillin for the Listeria plus cefepime that will cover the pneumococci, but will also cover other gram-negative rods that may be present in the immune-compromised patient. Meropenem is an alternative to cefepime, and if you use meropenem, you do not need to use ampicillin because meropenem covers Listeria. And if Listeria is isolated, then you need to add gentamicin to the treatment. You'll probably just do ampicillin and gentamicin, and you can stop the vanc and the cefepime. So it's not that complex, but it's got its little rules into it that you need to follow. The duration of treatment is 10 to 14 days for pneumococcal meningitis, 7 days for Neisseria meningitidis, and 21 days for Listeria monocytogenes. Now, if the patient has Neisseria, you may need to decolonize them, and because they can still keep the meningitis. I'm sorry, if they have meningococcal disease, they still may have the meningococci in their nose, and they can continue to infect other people. So you may need to add rifampin or ciprofloxacin to eliminate the nasal carriage. For Listeria, the gentamicin is usually 7 days. Unless the patient's not doing well, then you may prolong it to 21 days. So prevention. So we have vaccines against pneumococci and meningococci, but they're not recommended for everybody. They're only recommended for adults with risk factors for these infections. It's not part of the lecture to cover this. This will be a long topic to cover, but I just want to mention that. And also in Haemophilus influenza is usually not recommended for adults in general, unless they had their spleen removed for whatever reason, trauma or for an elective splenectomy. Then you need to vaccinate them for H flu. You would also need to vaccinate these patients for meningococci. And chemoprophylaxis, especially when it's meningococcal disease, there is an indication to prophylax with antimicrobials those patients or persons who had extremely close contact with the patient, basically households or medical personnel who did, let's say, resuscitation, intubation, a very close contact with those patients, not because you were there seeing or examining the patient, you need this. These are some references. And if anybody has any questions, I'm happy to answer them.
Thank you for a really wonderful presentation, Dr. Mira. Do we have any questions at this time for Dr. Mira? Once again, I'll put the survey link in the chat if you'll fill that out. Next month's echo is going to be on Wednesday, March 13th. I'll send out all that information in the wrap up that I send out after the echo. So you'll have that information, and I'll change the calendar invite to that date as well. Okay, no questions. Once again, great presentation, Anna and Dr. Mara. I appreciate it. And you all have a great rest of your day. Thank you.
Thank you. Good day.